truly honored to be joined on stage by some distinguished panelists and a topic that's very close to all of our hearts. How do we transform healthcare for the better? I want to start with a story. How many of you have heard of the man on the moon story? Anybody? You have, okay. So we'll share it with the rest of the group. So John F. Kennedy, President Kennedy, was touring the Kennedy Space Center in Houston many, many years ago, and he ran across somebody who was sweeping the floor. President Kennedy asked him, "Sir, what are you doing? Tell me about your work." The man stood up, said, "I am really pleased to meet you, Mr. President. You know, I am going to put a man on the moon." And this is the man of the moon moment for healthcare. We are all innovating, we are all doing amazing things in our own domains, but collectively, we now have to think about how do we create outcomes. Outcomes that improve access to what patients need. So without taking any more time, I'm going to turn it over to our first speaker, and then we will follow this up with some questions at the end. So,
good evening, everyone. So I'm Dr. Pankaj, Raina. I represent Becton Dickinson. So I lead the medical affairs for India, South Asia, and based out of Delhi. Sure. Yes, I do. Yeah. Oh, yeah. So good evening, and one of the common things that we see whenever a patient visits a hospital, like 90% of those hospitals receive any kind of an intravenous line, and then what the data says, and what the different studies are saying, that around 50% of these IV lines fail. When we say they fail, they are failing firstly maybe at the time of insertion. Maybe they don't stay for the time that they are intended to be placed in for. But if we are looking at those numbers, they are too high. That means every second patient is having an IV line which doesn't meet its real goals. So the failures, unfortunately or fortunately, are preventable. So these are like infections, phlebites, occlusions that we see, dislodgements, or extravasations. So if anything is preventable, so you don't need to cure it. You have preventive measures which can help you, and the quality of care determines how you can prevent those. And these complications are multi-start, and they affect everyone, all the stakeholders which are involved in the care process. Maybe patients, right? They get a lot of discomfort and pain. There is a delay in the therapy for that person, and patient confidence in the caregiver also is reduced. So clinicians also are stressed, and they also see clinical inefficiencies. They see clinician satisfactions go down. And again, for the administrators, because the reputation of the hospital goes down, the patient satisfactions are low, and the length of stay for the patients increases. So the question is, if we reduce these complications together, so that's the theme that we want to open up to you. So what we as an organization started, we discussed and we developed a program which was called Vascular Access Management, where we were auditing a hospital over a period of 3 or 4 days with 3 things in mind, starting off with practice assessments, so, and then followed by comprehensive portfolio of new products that can prevent those complications, and then trainings to the end users there. But the question here was not about implementing it programs. When we started off, hospitals were seeing complications, but they were saying, are we good bad, or ugly. So there was nothing that we could compare them with, externally as well as internally. So that was our first challenge. So we knew that what is their rate, but whether that is acceptable or that's not acceptable when it comes to complications. So what we did is we did the baseline clinical audits, we provided them recommendations, and then we re-audited them, and we see how things have changed. With respect to that, one question which we often used to get from them was, how are we doing with respect to other healthcare systems? So that's how we did an external benchmarking for that. So there were 40 hospitals, right? All of them were at an average bed size of 250, and we tracked around 1,600 hours of audit across those hospitals. And this tells you about the sheer size of the data, so that yes, if we are comparing them with another hospitals, it really makes sense. Then what helped us here is, right, you would be able to see the first, right, hospital baseline data, then the external benchmark was whether they are above or below it. Majority of the hospitals where we did it were our 7 hospitals, and post implementation what we saw was there was a significant improvement in the dwell time, which we say how long the catheter stays with that patient. There was significant reduction of around 22% in the complications, and the needle stick injuries, which is one of the key KPIs that the hospitals track, was reduced to 1. It also helped us look at how they are using technologies with respect to closed infusions. In those hospitals, it went from 37 to 64%, and similarly, the pre-filled saline flush, which is used for care and maintenance of the lines, also went up, which definitely shows that one is technology upgrades with closed systems helps reduce the complications and increase the dwell time for sure. Now, reducing complication, what does it mean for us? It means fewer restarts, decreased product usage.
Can I have your attention, please? Can I have everyone's attention, please? Can I have everyone's attention, please? We have a lot of ambient noise in the room. We're having difficulty hearing the speakers. If you must have a group conversation, can we request you to please step outside? Thank you.
Okay. So then what does it mean? Reducing the complications has 2 impacts, right? We have fewer resorts of catheters. It decreases the number of catheters that we are using. It reduces the cost of managing the lines per patient. It reduces overall cost, and there is a lower risk of complications to the patient. And you have longer dwell time, which is a positive thing. Increased patient satisfaction, which we measured, and we saw there was a significant improvement in the patient satisfactions. It enhanced the hospital reputation, because many a times you will see hospitals are being said that the first experience that they encounter in any hospital is when the catheter was inserted, and that's the first experience that they go with when they are moving out of the hospital. Then the experience of nurses, how did they measure them, and there are increased efficiencies in the overall care for the patient. With that, I would like to stop here and say, yes, improving the quality, you need to know the baseline, right? In our countries, unfortunately, many a times we don't have it. We also need to create our own local benchmarks with which you can compare. And third is, yes, look at the implementations and the guidelines that you are following. How is that going to impact you in your hospitals as we move forward? Thank you so much.
I invite our next speaker onto the podium, please.
Yeah, hi. Good evening. My name is Sachin Indane. I'm a co-founder and CEO of a company called Isansys. And I think as in line with the theme of the today's session of transforming healthcare and making a difference using technology, I'll be talking and giving you some glimpses about some very, very exciting and innovative technology that we have. So I would just request your attention for just about 5 to 7 minutes, and I'm sure you certainly won't get disappointed. Thank you so much, Dr. Manish. I'll be. Okay, good evening. So, as I said, Isansys is the name of the organization, and the solution is called Patient Status Engine. And as you can make out from the name itself, it's basically an entire machinery or the platform that is designed to give you status of the patient anytime, real time, from anywhere. Very important is it is a completely a digital healthcare platform, and that has been changing. Come this side, Shabazz. Changing the landscape of healthcare in India big time. A little bit of us, we are a UK based company. We've been in the market, one of the pioneers in this market from 2010. So as you can calculate, like 15 years we have been doing this in market, in global market. And 15 years is long time to master the art of the particular technology that we have, which we will talk about. And as you can see here, our vision for in the Indian healthcare is how can we help you people give a very, very high quality of medical services, but at the same time help patient and the hospitals reduce the cost. Now, one of the ways of reducing the cost both for hospital as well as for the patient is to move the patient from high cost setup to low cost setup. That means, from ICU to HDU to ward and even to homes, right? If you are able to do that successfully without compromising the quality of healthcare, I think all of us would like to do that, right? All hospitals will be happy, patients will be happy. I'm sure the insurers, the payers will be even happier than all of us. So we have a very strong legacy, and that brings the trust. If you look at this industry of ward patient monitoring, because now this is a new concept that's kind of coming up last 4 or 5 years, there has been a big surge in this concept of monitoring the high risk vulnerable ward patients. This is not ICU patients. These are the ward patients or HDU patients. So anything below ICU. And it needs a lot of trust. There are a lot of players in this, but that's missing in the industry right now is the trust from all of you. And we bring that. That trust comes from our strong legacy. The trust comes from regulators. The way you people get the trust from NABH, JCI, CARF, multiple agencies, for us, it's the regulators, right? So we get our solutions validated by US FDA, by European MDR, by India CDSCO, and we are the only technology provider who has all possible approvals for this particular technology. And as a result of that, in a very short period of 2.5 years in Indian market, we have been very fortunate to have the A category customers with us, and we are really thankful to all of these for trusting us. Now, what is that? What is the solution we are talking about? So it's basically a completely wireless patient monitoring platform. So as you can see here, we have my colleague here. If you can have a video on him, please. Hello, video master. Video master, can we have video on him, please? Yeah. Where is the sensor? Okay, so that's the technology that we have. So we have this sensor. We have a cardiac sensor that goes onto the patient body. It goes onto the chest, just on the 2 ECG electrodes, completely reusable. It basically uses a simple battery, Bluetooth enabled, reusable. You can replace the battery and use it. You can clean it. You can sterilize it. Then we have a temperature sensor that goes into axilla. Then we have the SpO2 and Bluetooth, blood pressure. The advantage of this is, as you can see here, there are no wires on the patient's body, or there are no wires between the patient's body and the bedside monitor. So the patient is completely mobile, can walk, can go to toilet, can sleep in any position, even go for rehab, do exercises, everything, and still getting continuously monitored. Then we have a very unique bedside monitor. That's not only just a display monitor, but it's also, you can enter data. You can see everything possible on that. As you can see all the parameters. You can see complete trained for each parameter. All the ECGs are seen that on that. You can enter data. You can select conditions like GCS, like patient is on oxygen or not. All that is possible on this bedside device. Now, once you have the data on this bedside device using very nominal Wi-Fi or even a SIM card, we are able to send this information on real time to your servers. Now, the moment you send the information to the server, it is accessible from anywhere in the hospital, whether it is from the nursing station or your command center or even on your mobile. Even the doctor's consultant can see their patient's information, from their consulting chambers. We also have early warning scoring mechanism, and very importantly, a detailed reports, dashboards, and patient reports, single clickable reports are available. All the vital signs are captured here. It's like heart rate, respiratory, SpO2, blood pressure, everything, and also a lot of manual entries we can do on this. This is how what you see. Not only that, we also have this in the HDU setup. So as you can see here, the small video that is playing now. On that video, this is the HDU setup in one of the hospitals in Bangalore. And you can see this is a respiratory HDU in one of the prominent hospitals. The question is how accurate it is. So it's like 100% accurate, gives you as accurate results as any of your minute monitors, whether it's from Philips or any other company, GE, it gives very accurate data. And that's what matters at the end of the day. Now, let me kind of quickly tell you how it is useful and where it is used in the hospital. So as I said, this is not for ICU. So this is used for HDU patients or ward patients or any high-risk patients in the ward or in transit, even at home, or any of the special procedures the patient is undergoing. Patient can be continuously monitored without any wires with very high level of accuracy and ICU level of monitoring. As all of you know, we have all these charts and everything maintained by the nurses. This is completely transformed into a digital form. So what we are doing, we are basically taking the digitization right onto the patient bed. Because today when we talk about digitization, we talk about digitization everywhere else. But the patient data, which is actual data on which the hospitals or the doctors take action, that is still manual. And we are able to convert that into a digital data right at the source of that data. And as you can see there, we have remote views which are available across the hospital, even on the mobile phones. And this is to avoid any kind of situations. We have WhatsApp alerts in case of patient's conditions change, or we also have audio alerts. We also have the screen pop-ups which come, giving you the enough time for the proactive action. You can see that some of the cases, all these are ward patients or home patients. Here you can see that the patient's saturation level, oxygen, the heart rate, you can see that the respiration rate is high, saturation is coming down, early warning score going up, and thereby you can see that the patient was proactively moved to ICU. A lot of data available. This is a road traffic accident case, came to one of the big hospitals. Very, very poor patient got onto the road and they got to the hospital, not in a position to afford. They managed this patient for 6 days in ward, and the 6th day patient got completely recovered without getting into ICU. This is another patient admitted in the hospital for a cardiac procedure, goes into syncope, and then when the syncope happens, nobody knows why and what's the main reason for that. Our system could capture the data properly. You can see that the ECG could see arrhythmic beats lasting for 30 to 40 seconds. And as a result, the cardiologist did not wait for the procedure which was scheduled for next day. They immediately got onto the cath lab and got the procedure done for the patient. This was a home care patient with bradycardia condition, went home, the heart rate dropped immediately, and as a result, patient was called back immediately to the hospital, put a pacemaker. You can see here, this is the patient which is undergoing robotic exercise in the rehab, and with the sensors and devices on his body, like the way my colleague Shahbaz has here. And the patient is getting monitored without any wires or anything. And of course, in transit at home we can do. So this is the technology which is transforming healthcare. It helps you all the way from clinical to operational to financial benefits. Very useful. We have, as we said, we know Manipal, Apollo, Fortis, Max, AIG, Arate. All these hospitals are using it successfully, and we can be very, pretty good technology partner for you to reduce ICU LOS, to reduce the emergencies, the code blues, improving nursing efficiencies, and kind of improving overall productivity, efficiency, and effectiveness of healthcare system. We'll be very happy. We have a stall number 10 just outside the exhibition area, outside the conference room. Please do visit. We are very happy. We are very passionate about this. And we want all of you to join us in this wonderful journey that we have begun. Thank you so much.
Thank you, Dr. Indane. One of the things that stands out for me is the talk this morning in the opening by Dr. Braithwaite about innovation and what it means to transform the 60-30-10 rule. And these two examples we've seen are really great examples of how we begin to address the 30 and the 10. And really it's the power of how do we actually look at procedural level innovation, how do we bring in training and automation, and how do we leverage the power of dashboards and data and real-time monitoring to really improve our ability to take care of patients. So our next speaker is Ms. Roelinde Bakker from Amsterdam, and we're going to talk about how do we actually lead organizations who may be in low resource settings through transformation, through the use of quality standards. So Ms. Roelinde Bakker, the floor is yours.
Hello, good afternoon, everyone. It's such a pleasure to be here with you today. It's my first time at CAHOCON, but it's amazing. Congratulations to the CAHO team. Congratulations to all of you. I want to talk about quality improvements. And I want to ask you a question. What is your dream? What is your dream if you look at quality healthcare and the national and international agenda? We know that a lot of patients don't have access to quality healthcare. And even today, we know that poor quality of care causes more deaths than lack of access to care. As SafeCare, we have a team here in Delhi. I am based in Amsterdam. We have a team in Kenya, Tanzania, Ghana, and Nigeria. And our mission is really to bring quality healthcare to the last mile and to reach the unreached. And we know that there are many challenges. There is a shortage of staff. That is something we see globally. We know there is an increasing demand because of the rise of NCDs. We know that there's a high out-of-pocket expenditure. And we know the pain points of the facilities. I have been to facilities myself in Ghana, in Zanzibar, and I have seen the complexities and the reality on the ground that patients are dying because there is no doctor or there is no nurse. But we know these deaths are preventable. So as SafeCare, we support and strengthen health systems and partners through a stepwise approach. So we provide certification, and it's really for facilities to help them to start their quality improvement journey. And it's really to make quality attractive, that they know how they can close the gaps. We use international accredited standards empowered by interactive data insights to drive structural change. Our solution focused on a stepwise approach. It helps and improve and sustain quality. It starts at the level 1, and we help facilities to prepare for accreditation to help them grow their level up to level 4 and 5. We have holistic standards, so it's really looking at the clinical performance and the management performance, because when we know that you can have a great clinical team, but if the laboratory is not functioning well, you can still have a bad outcome. It's really a team effort. HR, cleaning, pharmacy, all elements in the facilities come together when it comes to providing quality healthcare. And we know that quality is a continuous journey. It's behavior change. And the strength of a continuous digital process is that it starts with assessment, because you can only improve what you measure. After the assessment, the facility receives a digital quality improvement plan. And a digital quality improvement plan, it's tailored. So it's the gaps, the criteria that are linked with patient outcomes are prioritized. The facility is supported through our digitized platform that people can access on a desktop or smartphone, through our library, through training. So it's really about breaking down the steps so that it's achievable to work on quality as a team and to monitor the progress. Via the quality platform, the facility receives actionable feedback on the real-time progress, feedback, but also supporting documentation. So what do we see? We have 15 years of experience working in more than 9,000 facilities in 27 countries with 25 partners. And what we see, if you look at these examples from the baseline compared to the end line, and the baseline is the first assessment and the end line is the last assessment, there is improvement. We see improvement on all the criteria: waste management compliance, protocol compliance, resuscitation training, and available triage systems. But we also see that there is still work to do. It's also about how to sustain your level of quality. So if you look at our work, it's really about creating transparency on quality data by connecting partners. We work with private partners, for example, Aga Khan hospitals in Afghanistan, Pakistan, Philippines, and Kenya and Tanzania. In India, we work with Manyata, supporting more than 1,100 hospitals on MNCH care with the FOXY program that is led by the Manyata healthcare stakeholders. But we also support public partners like the regional or the national Ministry of Health. And by creating transparency, there is a possibility to have insight on the gaps and to prioritize the training, to prioritize the staff and the allocation of capacities. As SafeCare, we believe that every person has the right to quality healthcare. And we know currently also, for example, in Nepal, that a lot of facilities don't have access to quality for all kind of reasons. But with digitization, it's possible to reach those facilities. Especially during COVID, we were not able to visit the facilities ourselves. But because of the digitization, it's possible also to give remote support and to give interactive data insights. And we always work through local partners. So we train assessors in a methodology, and these assessors bring SafeCare to their clinics and to their hospitals. So we are really excited also here to start this journey with you. Because as SafeCare, we really work with partners, healthcare stakeholders in the ecosystem. And this is an example from St. Joseph Hospital in Kilimanjaro that participated in SafeCare since 2016. Quality of care is a right for every client who visits us. SafeCare helps us improve quality, which leads to more visitors and more revenue. Because of their journey with SafeCare, there was a more than 90% patient satisfaction rate improvement. There was a 25% increase in revenue since I reached level 5, and there was an increased staff ownership and service efficiency. So it's all about having a business model and a business case for the facility, but also for the network. And I have seen the impact of SafeCare at the patient level, because if they feel well treated, they come back to the facility. I have seen the impact for professionals because they feel empowered to work on quality. And as a network, there is more ownership and transparency where to invest and to allocate resources. So it's a privilege to be here today with you. We hope to see you at our booth. And for more information, if you are interested in working with us, we are especially looking at working with small and medium-sized hospitals to help them to start a journey towards national accreditation.
Thank you, thank you. SafeCare is doing some really important work and really aligned with what CAHO stands for as well, making quality healthcare accessible in Tier 2, Tier 3, and vulnerable populations. So congratulations and kudos. So moving from an organization that's enabling quality care to the masses in low resource settings, we want to go to pioneers of low cost procedures at Narayana Health. We have Mr. Jagadeesh, who's going to talk about their journey on innovation and transformation.
Very good evening to everyone. I'll start with a small anecdote. I think being in IT in healthcare, most of our timelines start from yesterday. We get the requirement today, but the timeline is always, I need it by yesterday. So in true spirit of that, I think Dr. Manish has given me the timeline of basically finishing this before I even start. So I'll keep it very short, and hopefully we'll have some quality takeaways from this discussion. So next is now, crafting the digital backbone of modern healthcare. That's a mouthful. So let's start by doing a small thought exercise, right? Let's wind back the clock. Let's go back 50 years. You enter a hospital. How does it look? You see a waiting lobby. You see a registration desk. You see somebody sitting there who will register you, and then you go meet the doctor. Then you get your prescription and you walk out of the hospital. Now, how does that compare with hospitals today? So this is a picture of an NHS hospital. The one on your left is on one taken in 1970, and the other one is a hospital taken today. There isn't much difference apart from the fact that they are split by 50 years and some interior decor difference. The processes have largely remained the same. So, automation applied to an inefficient operation will magnify the inefficiency. So we've been investing in health tech for a long time. If you see that 50-year time period that we just saw in those two pictures, that represents the bulk of investment that has happened, bulk of advancement that has happened in technology so far. But why hasn't it changed the way our hospitals operate? Why do we still have similar waiting time and the lack of, I would say, dramatic shift from where we were 50 years back? That brings us to the question, right? How do we view our investment in technology? How do hospitals and healthcare systems look at technology? Are they measured the right way? Are we measuring the right KPIs when it comes to how our investments in technology deliver in terms of whether it is reduction in operational burden, improvement in patient outcomes, quality metrics, or to put it in a business term, what is the return on the investment? The sad fact is that not much of our technology are measured with the right KPIs. And what we end up is a scenario where we have a lot of digitization, right? But without serious impact or change to the way hospitals operate. What we have are paper charts that are and long queues that have been replaced by their digital equivalent, but the decision making or the productivity of our manpower, whether it is clinicians or administrators, has not really changed. So looking at one of the most advanced or most digitized markets when it comes to health tech, which is the US, there the situation is pretty grim. That more than 60% of physicians are burnt out in terms of trying to keep up with all the digital interventions that have come up all this while. And manual errors still continue to happen despite rampant digitization. So, what is the doctor's dilemma? Like, are they supposed to focus on treatment or learn to log into 15 different applications that have been dumped on them in the name of digitization? Are we really solving the problem or adding on to it? Right? So, I don't have any direct or simple answers for this, but I can share from our experience what we have seen and what has worked for us in our setting in Narayana Health, in as Atma, where we have tried to solve some of these situations. Right, our focus has been to create a seamless integration of technology with the current process, rather than trying to change the process. How we can infuse technology which seamlessly connects all the various touch points in the hospital, whether it is bedside equipments or any other lab equipment, or the doctors or the nurses, how they all can be seamlessly connected, and how we can extend the care beyond the hospital, how technology can allow doctors to take care of patients even before they come to the hospital or even after they're discharged. And most importantly, how do we bring back the joy of care? So what we call is the approach that we've taken is coding by the bed. That is making doctors and engineers partners in this shared endeavor, where they are truly co-developing the solutions, and it requires that level of tight feedback so that the solutions can be improved and can be refined in a very quick time span. And a lot of focus on user experience. User experience is one of the single most important success factors that decide the adoption of any technology intervention in healthcare. And a lot of people confuse user experience with user interface, the design, how pretty it looks. That really doesn't matter. What matters is the experience. It's the number of clicks it takes to finish a transaction. It's the intuitive thought process that the product and the user have to align on. And finally, design a mobile first ecosystem that will help doctors and nurses truly become unencumbered from sitting at the desk to use their technology solutions. It has to be mobile first. And I've touched upon many of these in terms of how a solid bedrock of a unified EHR can put all these various solutions in perspective. Today we saw some amazing tech just before in this panel. At the end of the day, all that data has to flow in and help the doctors take that decision, make them more productive, make them more confident in their thought process, and be more when they can take care of much more patients. So we strongly believe that interoperability and seamless integration and decision support can go a long way in increasing our doctors and nurses' productivity without compromising on care. So we believe that the future is here, and we are going to see more and more hospitals where there are no back offices. Forget back offices, there won't be even front offices. Only people in scrubs will be in hospitals. All the other activities will be either automated or moved to an off-site location. And that requires a strong tech backbone. And we will see more stronger decentralization of care. Care will move out of the hospitals and move closer, more upstream towards the patients, to community centers and at-home care. And we also are seeing a lot of patients who demand more autonomy and more transparency in the whole process. And that is only possible if it is the entire ecosystem is completely tech-enabled, and ultimately leading to bridging the gap between demand and supply, and the patchy distribution of doctors across the country. With a strong EHR, we can predict a scenario where today's doctors can be 10x doctors. They can take care of many more patients without compromising on the quality. Thank you.
Thank you, Mr. Jagadeesh. So, just a few final thoughts. First of all, a big round of applause for the esteemed speakers here. So, I think we all agree that our man on the moon is ensuring that everyone has access to quality care. That's what unites all of us. And we all recognize that we are only as good as our weakest link. So innovation, quality healthcare should not be accessible only to the few, but to all. We also recognize that to really transform healthcare, it's the 30 and the 10 we really need to be focused on. How do we begin to align data, people, processes, technology to address the waste and the harm that we cause in healthcare, that exists in healthcare? Just to give you a perspective, globally we spend 10% of our GDP on healthcare, but $10 trillion. If I tell you 40% of that is wasted or causes harm, that's $4 trillion that add no value. So when we talk about where does the money come from, it is going to come from automation, data-driven decision-making, procedural innovation, standards-based practice, pioneers like Narayana Health who are actually driving the charge of low-cost healthcare and at the highest level, highest quality. So we have to really be respectful and mindful that we live in a time which is exciting, a lot of possibilities ahead, but that can be distracting. We have to be focused on what is our North Star. And CAHO has defined it for us. It is safety and quality, nothing else. But we also have to be mindful that our consumer, our patients are changing. When I started my career in digital health, it was a very different consumer market. Now the patients own cell phones, even in the poorest of the settings. They are in the 21st century. We must address their needs. Medicine is changing. Gone are the days when it takes 10 years, 20 years for bench-side research to get to the bedside. We have to shorten the cycle significantly, and we have the tools. And finally, technology is also changing. And by the way, this is not about technology, it's about people. So let's come together and let's put a man on the moon. Thank you all.